Welcome everyone to another episode of Move Well, Live Well, Perform Well. I am really excited today to have Dr. Nick Birch with us. We're going to discuss all things bone, and Nick is a consultant orthopaedic surgeon and one of the UK's leading specialists in spinal health, osteoporosis and early detection of bone weakness. He's the director of East Midlands Spine, CEO of OsteoScan and chief medical officer at OrthoSun, giving him a really unique perspective across clinical practice, diagnostic innovation, and medtech development. Nick's got extensive experience treating both athletes and everyday patients, with a deep interest in how bone quality, loading patterns, hormones, and lifestyle interact to create either resilience or fragility. He's one of the UK's foremost adopters of Echolight REMS, and we'll hear about that a little bit later, a radiation-free bone imaging technology that provides earlier and more detailed insight than traditional DEXA scans. And Nick helps people to understand why bones fail, how injuries can be prevented, and how to build stronger, healthier skeletons across the lifespan. So Nick, that's quite an intro. Welcome to our podcast.
Well, so thank you so much, and I'm really pleased to be with you, and thank you very much for asking me to join you today. It's been a privilege, and I'm really looking forward to the next hour or so.
Perfect. Nick, just to set the scene a little bit, how do you explain bone health to your patients or your clients in fairly simple terms? And what does having a strong bone actually mean?
So bone health is the totality of the way that your skeleton functions and the things that attach to the skeleton. So that's going to be muscles and ligaments. You know, you're a physiotherapist. You don't just deal with somebody's medial collateral ligament of the left knee. You will deal with the whole knee, and so you're looking at things really very much more holistically. And I think the problem that we have developed in this time we've got to has been focusing too much on one thing. So if you say to somebody, well, you've gone and had a DEXA scan and you've got a T-score, which is a certain number, and that then defines what treatment you should have. And by the way, you can come back and see me again in 5 years' time when you've taken the treatment and have another test. That's a really reductionist way to look at bone health. So we think about bone strength, and that then informs the discussion about bone health. What makes up bone strength? Well, there are 5 different groups of things that make up bone health, 2 of which are mechanical, 2 of which are effective dietary, and the third of which is then hormonal. So mechanical, we know that bone density has some predictive value for whether your bones are strong or not, but it's not the be-all end-all.
So Nick, just to backtrack ever so slightly, that's related to the T-score that you mentioned just a second ago.
Yeah,
so
or the Z-score, Simon. So we use T-scores for postmenopausal women and for men over the age of 50, and we prefer Z-scores for premenopausal women and men under the age of 50. So when we're looking at those numbers, that gives us a bone density. But you all will be aware that only about a third of women who have a fragility fracture have osteoporosis. 2/3 have either osteopenia or normal bone density, and the biggest number is actually in those with osteopenia. So if that's the case, and
which is frightening stats if you stop and think about it.
Yeah, it is. But if that's the case, then hang on a second. That means that the density is not particularly good at predicting who's going to fracture. And the reason for that is because density is only part of the story. The other part of the story is toughness. And it's a bit like if you have two rods, one made of steel, one made of glass. They weigh the same, they've got the same volume, therefore they'll have the same density. But if you drop them on concrete floor, they behave quite differently because the glass will shatter and the steel will bounce. So we need to know about bone toughness as well. And the technology does exist for that in DEXA because there's you know about the trabecular bone score, the TBS.
Correct. Yep.
Sure. So if you measure the trabecular bone score, you can pretty much measure the toughness of the spine. But what you really want to know is actually not just the toughness of the spine. You want the toughness of the spine and the hips, and that is not possible to measure with DEXA at the moment. But we can do that with REMS, which we'll get to. So they're the material components of it, and that's a bit like saying, okay, fine, I've got a car, and the car is made of metallic parts and plastic parts and rubber parts, and I know all about those bits, that's fine. But why is the car not going?
Yeah.
Because you haven't put any petrol or diesel or electricity into it. That's why. So now we need to know what is it that you need to put into your body to make bone. And of course, that is then effectively the story of calcium and protein, and
Yep.
how do we get mineralization? Because bone is mostly calcified protein. That's its
Yep.
major building block.
Yep.
So that's the dietary side of things. And then along the way with the density and with the bone toughness, you also need to then think about the exercise, which of course where you're a real expert at that. And so you're guiding people as to how to make sure that the infrastructure's there and then how to adapt that to make the bone strong. But one thing's missing. How do you repair bone? And this comes back to pretty much everything. Certainly in terms, if we're talking about athletes, if we're talking about postmenopausal women, how do they repair their bone? Have they got the normal remodeling capability that allows them, all those little micro cracks? And you go running, you go off and do your 10K or whatever it is tonight after this podcast, and you'll have thousands of little micro cracks in your bone. But by tomorrow morning, most of those are all started to heal because the normal remodeling process is doing a really good repair job.
Yeah.
But if you don't have the right hormones because you're postmenopausal and you haven't got estrogen, that process gets significantly disturbed. And that's when you start to see the deterioration after menopause, because it's absolutely required that you have to have the right hormones to make it work. So I think of this as almost like a five-legged table: density, toughness, calcium, protein, hormones. You can do all right with missing one, just about, but two, you've got a pretty unstable table.
So there's lots to dive into that, Nick. That was a really thorough sort of explanation. But bones gradually weaken over a period of time. Now, you've alluded to the fact that potentially that's hormones. And one of the things that we see with bone density issues, fractures, is that people's bone density slowly declines beyond about, late 20s, early 30s. Now, is there, and correct me if I'm wrong on that, is there a case for working with athletes in a younger age group to ensure that they are optimizing their bone health in the first place, so they're achieving that peak bone mass, so that we're reducing that slow decline?
Yeah, you're absolutely right. I mean, I've spent a lot of time over the last couple of decades mainly working with professional cricketers, some rugby players, some footballers, but mostly professional cricketers and mostly fast bowlers. And we see exactly this. And the problem you allude to is real, and it is concerning, because if you have athletes who are in their teen years and they do not know what they need to do to get to the very best bone they can, which is, as you said, around about the age of 30, it's called peak bone mass. That's the best bone you'll ever get.
Yeah.
After that, it plateaus for about 10 years. And in women then, by about the age of 45, when you're beginning to see menopause coming in, then it drops quite quickly, and then it slows down again after about 55, but continues to drop off as you age. Men, the drop off is slower, but it is there, and really beyond about 60, it's at the beginning to drop about similar sort of rate to women as the andropause comes in, so the reduction of testosterone. So
and that can be earlier in some people, in some males as well.
Some, sorry?
That can also be earlier in some males as well, with declining sort of testosterone levels.
Absolutely. Yeah. I mean, primary testicular failure, they're not producing testosterone, is a potent source of early failure. I mean, there are so many hundreds of other causes of it, but these are the natural age-related ones. So when we go back, if you had your time again, what age group would you target to instruct in the fundamentals of bone health and all the things that I mentioned about exercise and diet and all those things, and also hormones, because with women athletes, particularly in the teenage years and in the 20s, hormones play a huge role.
Yeah.
See, if you ask me that question, I would say teens. Get into
Yeah,
schools. Get
completely.
into schools.
Yes, so I think teens are the crucial. The evidence that I've seen, if teenagers are not playing lateral pivoting sports and loading their bones in a variety of fashion from age sort of 12 to 17, 18, then that can potentially be a problem in terms of achieving peak bone mass.
So there are two things there. That is such a refreshing observation because it exactly matches the observation that I have made and that many people in the professional cricket world have made over the last 15, 20 years. We have noticed that as you go to uni sports in teenage years, so you've got the fast bowler who's picked up at the age of 9, 10, 12, whatever it
Yeah,
might be. They're just around about puberty, getting into the growth spurt, bowling really quite fast, bowling accurately, and then they go down that single channel. But they're not doing enough sport to make their
yeah,
skeleton robust. They have to do multi-sports, but the schools don't do that.
no,
So by doing that, what you're doing is you're not making your skeleton robust enough to then be able to prevent the bone stress injuries which
yeah,
will come later on because
yep.
we see them 16, 17, 18. These guys are breaking down with bone stress injuries and different pattern of bone stress injuries from what we used to see,
Are
mainly
you?
because of the lack of exactly what you just said, and that is the lack of variation in sport that actually they are allowed to play.
I mean, it's this slight dichotomy, and working across various academies in elite sport, we see that there tends to be a push for these younger athletes to be pushed into specialising very, very early in their sort of preferred sport, which actually is more detrimental to their overall athletic development
Yeah.
and structural sort of development and movement awareness a lot of the time. Yet, okay, maybe it improves their skill based on in that particular sport, but it doesn't do anything else from an athletic development point of view, I think.
Yeah, I think you're right, and I think there's a couple of things there. One of which is that you've got the skills for, let's say, fast bowling, which is what I know about. So there's a certain set of skills, but that is not then giving you lots of stress in different ways, and
Yeah.
so you're then honing your skeleton to be able to do that. So you become, the Ferrari of the fast bowlers when you're 16, 17. But unfortunately, maybe a Ferrari that's built in the 1950s that's going to rust early because you're not going to last. That's the trouble.
Yeah.
Maybe it's not fair to call it Ferrari. Maybe it was a Fiat. Anyway,
No.
so there's that. But the other problem is that you've got two competing strands of coaching. One is the skills coaching, and certainly with the ECB, the English and Wales Cricket Board, with the Australian Cricket Board, with the New Zealanders, that has been recognised, and therefore limitation of number of overs that you can have a fast bowler when they're going through development is absolutely key. So that's good. That's been recognised, and it is applied in most cases pretty well, which is good. But you've also got strength and conditioning.
Yeah.
And the strength and conditioning guys are out there to try to make that player as strong and as able
As
as they
robust
can,
as, yeah.
but that there's enough crosstalk between the medical side on the skills side and the medical side on the strength and conditioning side.
Yep.
So I see, for instance, I have seen now, I've got a collection of about 90 cases of what I call vertical shear fractures, of basically where the pedicle and the facet joint complex in the lumbar spine effectively shear off. And
And this is different to your standard PARS injuries that you'd see in fast
the
bowlers.
standard PARS defect is almost horizontal. These
Yeah.
are very vertical. And it started to occur to me about 2006 when I first saw a pair of heptathletes, and they were training for the Olympics. They had exactly the same coach, and they came in within about 2 weeks of each other. They came to see me with identical injuries. They basically sheared off I think it was L4. It was the pedicle, that posterior part of the vertebra. It had sheared off the vertebra, and I just thought, hang on a second, what's going on here? So I spoke to them, and they
Can
said,
you
"Oh,
just
we're doing
explain?
weighted plyometrics."
Can
Oh,
you just
yeah.
explain, Nick, the pedicle part for our sort of viewers, if possible?
It's the little pegs of bone that stick back from the main part of your vertebra. The main part of the vertebra is like a drum, and from that you've got two pegs of bone sticking out the back, and then there's a ring of bone that forms, and within that are all the nerves and spinal cord. So those two
Perfect,
pedicle
thanks.
struts link the front and back of the spine.
Yep.
If you then put too much pressure through those, they can then break, and that's what happened to these two girls. And then they told me about the regime they had. They said, well, we're doing weighted plyometrics. And I said, well, how does that work? They said, well, we get a bar on our shoulders, and these are 55, 60 kilogram girls. And yeah, they're international heptathlete standards, so they're very, very strong.
Yeah.
But we then get a 75 kilogram bar, i.e. above body weight, and then we do some star jumps and some burpees and some plyometrics, etc. And not surprisingly, when you do that, I mean, you must have done some.
Yeah, I mean, there's a huge amount of force.
What is the ground reaction force going through their legs
Yeah.
and go through the spine there? I mean, it is huge, absolutely
Yeah.
huge. So not surprising.
I would like to think that plyo's done like that. There's some evidence for that, but they're done at a much lower load to generate more speed. Because
not 1.3 times body
Yeah.
weight. Yeah, so yeah, that was the anyway. So that led me onto it. Then I started to look hard, and I've seen now, as I said, I've got a collection of about 90 professional sports people with very similar injuries. And what I noticed is that if we go back to the teens, what's happening is that these are often they're men, they're gangly young men. They've
Yeah.
shot up like a
Yeah.
beanpole.
Yeah.
They don't have the skeletal maturity to protect their bones.
Yeah.
They're growing at such a rate, they can't keep up with the nutrition. So they can't keep up with the calcium, the protein intake, and all the other key nutrients, etc. So effectively, they're getting this reduced energy availability,
Yeah.
sort of red S syndrome.
And also the amounts of load. Like I've got two young boys. One of them's a very good fast bowler, and he's suddenly 5'10", 5'10" and a half, and eyeballing me, and he's still a bit wobbly and floppy in parts. And we're trying to put him through his S&C program. He's at a school that is fortunate that does some of that, and he's starting to develop that. But there's a lot of schools that don't have that, and they're just playing a hell of a lot of sport.
Yeah.
So it's impact after impact, rather than building that robustness and that strength within the system.
But also, just looking at the dietary side, I don't think enough schools concentrate on just actually how much fuel these kids need to feed the machine. I mean, many of them, when they are that sort of age, 15, 16, are going to need 3,500, 4,000 calories a day. To one, to do the sport, and two, to fuel the growth, because they're still on a massive growth curve. So if you say to somebody, well, look, you need 3,500 calories a day, what does that look like? That's a shed load of food.
That's a lot. I work in the cycling world and live in the cycling world, and they're eating these enormous portions, and perhaps there needs to be a bigger role in schools around that. Now, you mentioned the term red S just a second ago. Just to elaborate, that's relative energy deficiency syndrome.
Yeah, or relative energy deficiency in sport, depending on which paper you read to begin with when it first came out. So this is effectively, you've got an athlete, and I'm going to use a female example on this because I've talked enough about men fast bowlers. And what she's doing, she's a runner. Say middle distance running, sort of 1,500 meters, and she's chasing her personal best, her PBs, and she's thinking, okay, right, well, I'm weighing in now. I'm 165 centimeters tall, and I'm weighing in at about 52 kilograms, and I'm not hitting my PB. So I need to hit my PB. How do I do that? Well, the only way I can do that, because I can't make my legs move faster with my weight, I've got to lose some weight. So I'm going to slim. And then, of course, then you get into this cycle whereby they are reducing the energy that's going in, and they're still not getting their PB. Yeah. Because they haven't got enough energy, because they've got relative energy deficiency, because they're not feeding the machine. What they should be doing is saying, actually, to maintain to get my next PB, I need to give myself more energy, not less. And then
partly because they're probably training harder to to try to optimize that.
Yeah. And then, of course, what happens, of course, is that as the weight goes down, then you start to get physiological changes. So the body mass index goes down. And then the body starts to go into protection mode. And one of the things it begins to shut down is the normal menstrual cycle.
Yep.
And so therefore they're going to be depleted of estrogen. So then the whole of the organism is not got the right level of hormones. And then you start to get the little cracks and crevices. So they're running more to try to get their PB. Their estrogen's falling off. Now they've got the little cracks and crevices, the micro cracks that come along with normal activity, but they haven't got enough remodeling to repair that. So then they start to get a breakdown, a stress breakdown. And so they then got the shin splints.
Yep.
And then goes on to this
Or femoral neck stress fracture, or
and the whole thing.
Yeah.
And you know, and so that is. I've seen a few cases in my career. I'm not primarily a sports med doctor. Mine has been spine and spinal surgery, and then sort of spinal medicine. So I'm looking really at the spinal side of things, but I'm very aware of it, and I have seen a few cases of more peripheral bone stress injuries. And I think the messaging there, the thing that I would say to people is that we need to have, take for instance Dame Sharon Davies. She needs to be, if she doesn't need to be, I'd love to see her doing Instagram things, saying to girls, you need to be my size, because this is how you get to be a world champion. This is how you get gold medals. You don't need to be the sort of, if you like, the idealized, very slight person on Instagram or on any of the other social media channels where people are almost glorifying in this sort of very, very, what used to be called size zero, and that we've got to get away from that. We've got to say to people, if you want to compete, you need muscle.
Yeah. So I think, we're talking about having a very athletic frame and a strong frame. And I think there's been more of a push with that amongst females, but I still think the message doesn't hit home as well as it should do, because I think a lot of people underestimate how hard it is to balance, balance training load, balance energy intake, balance the recovery. Sleep, I think, is really, really essential for optimizing bone health, optimizing your recovery parameters. And if you're not getting that balance right, it's quite easy to fall into that sort of overload. And Nick, correct me if I'm wrong, but because of our computers still work in that survival mode a lot of the time, bone is one of the first things that the computer that bone metabolism, it almost shuts that down as an early protective component when someone is slightly energy deficient or something else is going on within the system that it needs to protect.
You're right. The endocrine control of bone health, of course, is extremely sensitive. And if it looks like you are depleting yourself of the key nutrients that you actually need for your body to work, and so there's a shift, then very quickly there will be that change. And as you say, it'll shut down. So I think the problem with this comes with the long-term lack of energy, the long-term overtraining. But I think going to one of the things that we're talking about teenage athletes. We mustn't forget that teenage athletes are developing not only physically but also psychologically.
Mm-hmm.
And the influences on...
But actually REDS doesn't, or bone stress injuries isn't just teenage years either, is it?
No, but I think one of the things that's key here, Simon, is that unless we actually recognise the environment in which then teenagers and young women, particularly, are growing up in, and the influences that are on them, particularly with social media, which I see, I saw a lot of that. I mean, back in the early days of Facebook, I started to get in my clinic a lot of patients, a lot of teenage girls coming in with chronic pain. Mm-hmm. Chronic, really, seriously. I mean, they'd had pain for months. And I couldn't figure out what it was because nothing had changed in the way they were presenting. There weren't any more bone stress injuries. There weren't any more adolescent discs or anything like this. And then one day I saw a girl and her mum, and the girl was head down. She wasn't looking at me. Her mum was talking to me and basically giving me all the history. But this girl was head down, and she had a smartphone in front of her. This was about 2005, 2006, probably early days of Facebook. And I said, "What are you doing?" And she said, "I'm looking at Facebook." And I said, like,
You're showing your age now, are you, Nick? I
yeah,
mean,
I am.
Facebook doesn't.
Yeah. So the long short of it is that I try to interact with social media as little as possible, as close to zero as I can get, because I think it has, in certain circumstances, and not necessarily positive influence on people's lives. And this is one of the things that I noticed, that in teenagers, boys and girls, then they would potentially have a negative psychological effect from peer review, etc. So I think that carries through into the 20s as well. So there's you and I know also that certainly since COVID, there has been a massive uptick in mental imbalance.
Yes.
People are not balanced.
Yeah.
They're not necessarily mentally ill, but they're not mentally balanced necessarily. There's a lot of anxiety.
There's a lot of stress.
A lot of changes in population, a lot of stress. One of the things that stress does, of course, is it drives the adrenals to put out cortisol.
Yeah.
And that in its own right is going to have a negative effect on our bones. So we've got a whole bunch of different things, all contriving to make life difficult.
Yes. To
and,
get
and
that right
unpicking
balance.
that, where do we start, is really interesting, but also very important and urgent.
Nick, just coming back to some of the athletes, do you see, and you work predominantly with cricketers, but in your time of seeing a lot of different patients, are there particular groups of athletes most at risk, like runners or dancers or cyclists even, gymnasts or cricketers? From these sort of bone stress injuries or REDs in particular?
Well, if we talk about bone stress injuries, which I do know a bit about, then classically, of course, it was gymnasts in girls and cricketers in boys. That's changed a little bit as the years have gone by. I now see bone stress injuries in a wider range of sports, and that goes back to what we were saying earlier, and that is essentially if you train a teenager in a uni sport and don't allow them to then have multiple sports, then you're not then going to give them robustness. So I think that's definitely a different pattern, and it has evolved as time's gone by. So with regard to RED-S, that's possibly related to a whole bunch of things that we've just really covered. So are we going to see more of it? I hope not. Can we get to you, Simon, are really important because you're the generation younger than I am. I'm just an old guy.
I'm not sure that I'm that much younger than you, but yeah.
Yeah, but actually, what you can do is you can get the people that you work with to get to the schools, to get to the academies, to get to the sports clubs, to get the knowledge there that we've got to change things around. I gave a lecture about 7 or 8 years ago, and I took the bone density plots for age 20 through 25, and I demonstrated to the audience that if you had a shift of just 10% in your bone mineral density at the age of 20 across the population, by the age of 85 you'd eliminated osteoporosis.
I mean, that's quite remarkable.
It's not possible because nobody has had a public health program that's run for 85 years.
Yeah. I mean, because, we see something that the stats are that, almost 50% of females over 50 will end up with osteoporosis, but undiagnosed a lot of the time, and almost 30% of males.
Well, that's because of the arbitrary nature of the diagnosis of osteoporosis. You know how osteoporosis was defined?
Yeah.
So 1992, there's a conference where the World Health Organization brought together all the world's experts on osteoporosis. This is the early days of DEXA. So they didn't have much in the way of literature at that time to go on. And eventually what they had to do was they had to say, well, look, we've got to draw a line on the graph somewhere. Let's draw it here. And that's a T-score of -2.5.
Yeah.
And that seemed to be a reasonable thing to do. And what they said was that anybody below that line has osteoporosis. Well, if we know that there is a gradual reduction of bone density through age, then of course what happens is you draw a line across a graph as a straight line, it's horizontal, then more and more people can become osteoporotic as time goes by. So that's a natural consequence of the mathematics of the graph. The bit though that's important is to say, well, actually, you know what, if you're a 70-year-old woman, and I don't know how many of your clients are in the sort of 60s and 70s, but if you see a fair number, you see some veteran athletes. These are tough people.
Yeah.
And
Yeah.
they may have a low BMI and they may have a low bone density because they've got a low BMI because they're very slight people. But really whippy. I mean, they're like whippets.
Yeah. Yeah.
But they are tough. And when I measure them using REMS, their bone toughness scores are superb.
Yeah.
So although they might be arbitrarily in that diagnosis group of osteoporosis when they're 70, because that's actually just where the line is drawn, actually their bone health, when we look at it in the round, is very
It's
much
good.
better. Much more like a 35-year-old.
Nick, as we've just started to dive into it, because we've covered lots of different aspects already, can you touch a little bit on the imaging and the difference between the bone density and we call it bone fragility, but I think we're talking about the same thing in terms of that sort of bone toughness that you're alluding to when you're using a REMS scan or an Echolight scan. How much more information does this give you when you're advising your clients and patients?
So go back to my definition of bone strength to begin with. Two mechanical components to a bone, density and toughness.
Yep.
Now, we know that both contribute to overall bone strength, but we also know that toughness is the more important of the two when it comes to breaking.
Yep.
So the first thing is that people seek out REM scans because they want to know not only what their bone density is, their T-score is, but they also want to know what their bone toughness is, because they know that bone toughness is more important to say, am I more at risk? Because this is all about risk, nothing about. So effectively what we're doing is we're measuring the parameters in bone to say, are you at low, medium or high risk in the future of having a fracture? Because that then governs what you can do. So go back to our 70-year-old veteran athlete. Can she continue to pound the streets of London, running round and round and round Grosvenor Square, waiting for you to open your doors at sort of 6 in the morning because she wants to come do something?
We have quite a few of those.
I'm sure you do.
Yeah.
Back in my youth and heyday, I used to run around Green Park, and that was great every morning at about 6 o'clock. And it was even then back in 1979, there was still a lot of runners out. So we're looking therefore to give people information about, okay, what's the totality of your bone? We know what your bone density is because it's governed by age, weight, and diet, etc. But we know also that your bone toughness is almost uniquely determined by your physical activity, and particularly impact activity. So if you're doing lots and lots of impact, then you're likely to have better bone toughness than if you're doing not lots of impact. And that is a feature of looking at the overall bone health of people that is so important, because people are aware. I mean, you will have people coming along to have REM scans with you who are fully aware of what all the limitations of the various technologies are. No technology is perfect, we know that. And that's fine. REMS has got limitations, DEXA has limitations, quantitative CT has limitations. But when you're looking for something that's going to give you an overall package to look at your global bone health, then REMS offers unique additions that is not available by other technologies. Because REMS can do your fragility score, which is your bone toughness, and your bone density for both hips and the spine, and if the module is fitted, it'll also do your body composition. So you've got a whole range of different metrics that you can use to help to advise a client that comes into your practice and say, well, look, this is what you've got, this is where you are. Sure, your bone density is this level because this is actually what your bone, what your body mass index and your age is saying it should be. But your fragility score is really low. You're in that nice green zone. It's really, really tough. and you just carry on doing what you're doing. And by the way, the reason why you have got an injury to your knee isn't because you've got a bone stress injury, it's because you trod on the pothole and you strained your medial collateral ligament.
Yeah.
So all of that is really what people are looking for now. And REMS as a disruptive technology is important because actually it's giving people more than what's been available before. And it's going beyond it. Have you seen any of Kim Zambito's webinars that she's done? She's a hand surgeon in Pennsylvania, and she and I have written some blogs together and done some recent.
I don't think I have. I'll have to check it out.
So Kim's great, but what she has, I mean, Kim's whole approach to this is defined by one sentence: you're not just your T-score.
Yep.
So important.
But that's a big part of the problem. But also the other flip side to that is that the availability of the existing technology, be it DEXAs, is very difficult for people to access a lot of the time. The nice guidelines on how to scan and screen people don't allude to this sort of silent epidemic that we're sort of facing with bone health, which is why, having more available Echolight REMS scans for everyone is so critical, I think. And it's what we use within our clinic because it gives us another layer of information and how we can load people effectively.
Yeah, so I think there are two things, aren't there? One of which is, are you using REMS for screening of a community-based disease, i.e. fragile bones? Mm-hmm. Are you looking at it as a risk management tool? Now, when you do that, you have to look at it and say, okay, well, a screening tool has to be accurate, easily reproducible, cheap, and you can apply it to people who are likely to have the condition. So do all the case finding, etc. So that's fine if you treat bone densitometry on that level and say, okay, so for the population, we're trying to use a test that can detect whether you have a bone condition that makes you at risk or not. Yep. Great. Well, in many respects, FRAX does that and does it pretty well, particularly the latest updated FRAX Plus. So you can do a lot of that without having to do densitometry. But the trouble with just looking at the densitometry is it's only looking at part of the structure of bone. It's not looking at the bit that's actually really important, is what you just said, and that is that if you've got a runner, so say the runner, say she's had a stress fracture, or no, just say shin splints, and she's come into you with shin splints, and then you said, okay, fine, well, we need to know when we can reload you. We know that if you offload athletes who've got good bone density because of their athletic activity, their bone density will change relatively quickly. We see it in cricketers all the time. There's a really good researcher in Loughborough called Pete Allway who's done a huge amount of work on this. And we can look at the fast bowlers, and they have supernormal bone density when they're bowling. And as soon as you shut them down when they've got a bone stress injury, it just drops off a cliff. But then
is that right? And how quickly does that drop off?
Oh, within a few weeks.
Wow.
Oh, really quite quickly. Yeah.
Can you pick that up on an? Is the Echolight REMS sensitive enough? To identify that?
So I've done a lot of these players as well, and it pretty much matches the DEXA. So it is good. So that's great. But what it also means is that you've got this radiation-based tool, and we know that you don't really want to put people through radiation tests when they're very, very young, or at least you want to minimize the number. Now, DEXA has a very, very low dose of radiation, but it's cumulative through your life. You just don't know what's going to happen. You don't know whether someone's going to get down, in 10 years' time and need to have a whole bunch of different radiation investigations. And maybe that little bit they had when they were a fast bowler, maybe that's going to be, not very helpful. We don't know that. So what we'd like to do is reduce the amount of radiation possible. Now, if you've got a tool that can track the recovery of the bone as you get back into normal training and then get back into normal playing, which is what the REMS device will do, that's valuable because it's it's ultrasound, it's not radiation, it's completely safe. You could have, Simon, you could have a REM scan every single day of your life, and you would not be
no radiation.
one jot worse.
Yeah.
So the value in that is actually the ability to use it as a tool in a different way from screening. There's screening and then there's treatment.
Yep. Okay, fascinating. So we tend to use REMS with some athletes, but also from a screening point of view, because it adds that layer of information in terms of the fragility or toughness of the bone. Is there, we tend to say that actually we should be screening people earlier than what is standard guidelines because of the risk of these fractures occurring in people who aren't aware of that. Because once someone is aware of their bone density or bone fragility, they can start trying to change this. And osteoporosis, if it's been diagnosed, can be reversed and can be changed and altered the course of that. And that's, I think, an important point to mention with people.
I couldn't agree more. And I think that there are a number of key ages when you might want to screen somebody to give them, first of all, a baseline. And that is after age 30, when they've gone through peak bone mass, between the age of 30 and 40, when they're on that plateau, then you'd say, okay, look, let's get your baseline. And if there are some deficiencies, we're going to give you a plan to how to deal with those before you hit menopause, because you've still got all your hormones on board. Therefore, all the things you do will be effective in building your bone, building your density, building your toughness.
Yep.
So that's the first time. And then the next time then...
So you're saying sort of between 30 and 40 almost?
Yeah.
Yep.
Yeah. And I'm seeing now, I'm beginning to see a trickle of women who are coming along and exactly that. And they're asking me that. So the word's getting out there. I want a baseline.
Which is great, which is brilliant.
Yeah, it is. And hopefully that trickle will become a flood. Now, once you've got that, you also need, though, Simon, you need to have what goes with it, which I know you have with Paul McGee, and that is you've got an expert who can then put that result into context.
Yep.
And I'm sure you have also exactly the same knowledge. You might not be driving the probe, but you've got exactly the same knowledge. So you've got a group of people who can then give a client that expert knowledge and your expertise, and put it into the context to say, okay, this is where you are.
Yeah.
Fantastic. This is good. That's good. That's good. But hey, look, let's tweak this, because actually, if you do this, then in 10 years' time, the likelihood is that you'll be better off. And then you're not going to be having a problem. So then we get to 10 years' time, which is perimenopause. So we're starting to change. You see the changing now in the estrogen and progesterone levels in the body. So things are beginning to change at bone level, cellular level of the bone. Now we want to know, have you stayed where you were when we measured you first, age 32, and now you're 44, or are you different?
Yep.
So if you're different, are we making some different decisions? Are you seeing a menopause specialist? Are you thinking about maybe hormones are going to be part of the discussion now? Again, you've got to go through the diet and the exercise side of things. That's a given. That's fine. And then as soon as you've then done that, if they're not going to go on to hormones, there might be lots of good reasons why they can't. Then as soon as they actually then have the diagnosis of menopause, which is 12 months from the time of the last period, then you do another one, because that's when you hit the slippery slope. Now, you know, and I know that the bone loss in women in the first 10 years after menopause can be up to 2% of bone mass per year.
Yeah, it's massive. It's sort of 3 to 8%.
After that, it goes to about 1%. So, but that means that let's then take our idealized. So the average age of menopause in women in England is 51. So we've got a lady who's 51. She doesn't know what her bone parameters are. She then gets to the age of 66. So she's 15 years in.
Yep.
She may have lost up to 20% of her bone mass in the first 10 years, and then another 5% in the subsequent 5 years. She's lost a quarter of her bone mass.
Which is just an enormous amount.
And she could have done so much about it had she known.
Yeah.
But why do I choose the age of 65?
Oh, well, that's where that bone loss bone density drops off significantly more as well,
No,
over sort of
no,
60
it's
odd.
not, because that's where the national guidelines say screening should start.
Yeah,
Both the American guidelines, the Australian guidelines, and the UK guidelines, they all say screening starts at 65.
which is for a lot of people too late.
Well, it could be too late. If you, I mean, given that the risk of having a fracture after the age of menopause obviously is going to be significantly increased. If you haven't had a fracture, then your risk is going to be, whatever it is. But if you have
Yeah,
had a fracture, your risk is doubled.
yeah, yeah.
So,
And we
so
know that
when it is too late,
if you've had a fracture over the age of 60 of your hip, the mortality of that in the first year is incredibly high.
Okay, so this is an urban myth, and I'm really actually grateful for you to raising this, because I explain it to women all the time. The mortality of a hip fracture in a frail elderly woman is high, up to 14% in the first month and up to 30% in the first year. And if you survive the first year, you've only got a 50% chance of getting back to the previous level of mobility you had. That is in a frail woman. If you are a strong, robust woman, so if you are, Simon's, sort of veteran runner who's 70 years old, and she's running and she's really strong and she's robust, and she trips over on a pothole, she falls over and breaks her hip, her chance of dying in that first 14 days is tiny compared to the woman who's frail.
Yeah.
So this comes then to the point we haven't yet discussed, and that is sarcopenia. Because unless you know about sarcopenia in a woman, you don't know whether she's frail or not, and therefore you don't know whether she is at significant risk of the really nasty adverse consequences of a major fracture like a hip fracture. So we need to know more now about the musculoskeletal system in general, and so we need to do some sarcopenia testing.
So for all our listeners, sarcopenia is muscle loss. And we're seeing this, it's getting a lot more awareness at the moment, particularly with our GLP-1 agonists, because a lot of people who are taking these are losing a substantial amount of muscle mass associated with this. So sarcopenia is a real issue in people, and strength gains or strength training helps load bone, but it helps to maintain this muscle mass. And if someone's not doing that, they're missing a big trick.
Yeah, and I think the other thing is that there's a term that's recently been introduced, which I came across, was dynapenia. So sarcopenia is the absolute loss of muscle bulk. Dynapenia is the loss of power. And it was quite an interesting article in the Journal of American Medical Association last week or week before that, and I thought, oh come on, this is just somebody's invented a new term because they wanted to get a new word in. But actually it made complete sense, because you can lose muscle bulk, but you can be wiry. You can still have power, but it's the combination of muscle bulk and muscle power that's lost that really is the thing that leads to frailty.
Yeah,
And
I mean,
frailty is our biggest enemy.
I recently ran a presentation at a conference on the power of muscle, and actually power is one of the markers that we lose first before strength and then muscle mass. And, we need power purely because if you trip over, what do you need to do? You need to get your foot out really quickly to stop you falling over. And that comes with speed of action. And if you're not doing some work to help to train that, then actually it's quite easy for that power to diminish as we age.
Yeah.
Nick?
And that then comes to falls prevention and falls risk.
Yes.
So it's all very well having someone who's still training, it's still doing stuff, but actually if they're losing balance for whatever reason, and I've got very, very good buddy of mine is Professor Bill Ribbons, who's been a sports med prof at University of Northampton for goodness knows how long. And he's
wrote a good book.
Yeah, knife in the fast lane. But he starts off with the basics of what's the foot doing, what's the biomechanics of the foot. So if we ignore all these bits, outside the spine, outside the hip, etc. And we say, actually, what we're really interested in is the T-score of the hip. Well, no, we're not really, because what we really want to know is what's happened to the arches of your foot.
Yeah,
And
completely.
are your feet working properly? And if that's working properly, are your ankles working properly? And then are your knees working properly? And then your hips, etc., etc. So I just
Well, it's
think
the whole
that,
kinetic chain that you need to
correct.
assess and to look at. So looking at how someone moves effectively has got to be part of this whole process.
But then start up here, because then what happens if you start to get some neurological problems, or maybe then you start to get some wear and tear change in your neck, and maybe get a bit of pressure on your spinal cord. So it's top and bottom, and I just think that there's so little joined up thinking. And overall looking at people, and I mean, not necessarily just athletes, but sort of normal people who do park runs.
Completely. Yeah.
Everybody.
And I think that's a problem in medicine, is that we're siloed off a lot of the time. But
Yeah.
Nick, can I dive back into some practical advice that we could give to people? So we've talked a lot about the ramifications of bone density. We've talked about how bone toughness is super, super critical to adding another layer of information for bone density. But what are some of the easy things that people can go away and start doing to think about their bone health? Like, clearly, okay, that's potentially different at different stages of people's lives, but are there some easy, practical solutions that you could provide to people?
So if we break that up into two areas that are really important, one is diet, one's exercise. So let's start with the diet first, because what you need to know is you need to know what are the key nutrients that you need in your diet every single day, how much you need to have, and where the foods that you get those from, where they all come from. And it's pretty straightforward, because at the end of the day, it's a story about how does calcium get to meet protein, and then make calcified protein, which is bone. And the story is in two parts. One is transport, and then the other is building calcified protein as a chemical process. The transport story is vitamin D3 and K2.
Yep.
And the biggest lack I see in this country and the Western world is failure to understand the interaction of the transport vitamins with magnesium and with the various structures that you're looking for. So vitamin D3 is absolutely essential, we know, for calcium to be transported from the gut into the bloodstream, and it works with magnesium. But to get it from the bloodstream into the bone, you need vitamin K2. Now, if I say to a doctor who doesn't know much about nutrition or diets or bone health, my patient needs to have vitamin K2, they'll look at me and say, why do they need to have a clotting vitamin? And I say, well, hang on a second. No, that's a phyloquinone. This is a menaquinone. So that's why it's called MK4, MK7 are the two commonest ones. And it's a failure to understand. So we have a lack of training in nutrition in the medical profession in the Western world. Whereas you go to Japan, you know about natto, don't you?
Yeah.
Yeah. So natto's got the highest concentration of vitamin K2 of any food in the world. And Japanese doctors know about natto and K2, and there's been extensive Japanese literature on the beneficial effects of K2 on fracture prevention. But you go to the Western world where it's not so well known.
It's unheard of a lot of the time.
Yeah, I mean, people say K2 is found in a lot of fermented foods, but how many people in this country eat huge amounts of
Kimchi
or kefir, or krauts,
sauerkraut.
We eat yogurt and cheese, and a bit of cream maybe, but you're not going to really get all the K2 you need from that. You need to have fermented foods, or you need to have a supplement.
So vitamin D3 and K2 as a supplement. Vitamin D3 and K2 as a supplement.
Yeah, absolutely. And they come in. There are semi preparations where they come together, which is great. So I think that the nutritional world are so far ahead of us with all this. That I talk to the nutritional therapists. I mean, these people are. I mean, they're super bright scientists, and they know. I look up to them as gurus in the nutritional world, because they know vastly more than I ever go to know. I have the very basic understanding. So I think if the first easy grab, Simon, is get the nutrition right.
Yep.
And once you've gone beyond K2 and D3 and magnesium, then you've got vitamin C, you've got vitamin B9, which is folate, you've got boron, zinc, manganese, copper, silica, all those things. And then I'm going to ask you a question here. What do you recommend should be the level of protein that your clients should have, grams per kilogram of body weight, when they're doing training, recovering, etc., etc.? I know what I say to my clients, but what do you say to yours?
Minimum 1.5 to 2 grams of protein per kilogram of body weight. So probably the higher end of that, sort of 1.8 to 2 grams, and that's perhaps controversial. It's way above the recommended sort of dosage limit, but that's what we consider critical in our sort of population.
For most women that I see who are only moderately active, I say 1.2 to 1.3 grams per kilogram, and if they're very active, 1.5 and above. And I completely get that and agree with that. And I say that the range is 1 to 2 grams. Yep. Right at the bargain basement down at 1, that's pretty much where most of the population is.
Yeah.
And the big problem with that is that as time goes by, the appetite decreases as you get older. And if you don't prioritize protein, what happens is you all your food groups on the plate gradually shrink in proportion. So you're getting less and less protein when you need more and more.
Yeah, and also we metabolize protein slower as we age, or poorer. Yeah. We're poorer to metabolize protein as we age.
Yeah. So I think the first grab is to say get the diet right.
Yep.
The second grab is do the easy exercises, do the heel drops, do the sit to stands. Get some grip strengtheners and really do all your upper limb stuff. Do some when you come down the stairs. Pretend you're an elephant. Come down really heavy, bouncing. Yep. Any impact. Get to the bottom step, and as long as you've not got sore heels, jump off.
Yep.
And do it slowly to begin with, gradually build it up. So anything's impact. And if you're doing heel drops, just do 5 at a time. 1, 2, 3, 4, 5. That's it. Leave it for an hour. Let the bones sort it out. They will do. Come back in an hour, do another 5. Go and turn the kettle on. Do 5 heel drops. Go and do something else. Do 5 heel drops an hour later. These are all simple things. They cost nothing.
So you're talking a lot about great incidental sort of things that people can integrate into their life.
Yeah.
Which is brilliant. I mean, we know about the Lift More trial and lifting heavy weight, which has been shown to reverse osteoporosis. But I think, making people aware that there's lots of incidental, simple, easy things that you can do that actually helps maintain and can improve bone density depending on what you've been doing previously.
Yeah. I mean, Lift More and Belinda Beck's trial was just astonishing. I mean, it was a real game changer. And as you say, it is possible with the right directed exercise to reverse things. But it's that word directed. You have to be with a trainer. You have to get good form. You can't just go out and just decide that you're going to be lifting these great big weights by yourself, because otherwise something's it isn't going to be right. And there aren't that many around the country. Bex Morant, who's a phenomenal physiotherapist down in Brighton, she runs a program which has got a passing reflection of Lift More, but it's not the same idea. But there are a few of them. There's a wonderful guy in Bristol does it, but I don't know that many.
I mean that's
therapists are really interested.
That's what we have developed in conjunction with our biodensity machine, and we run a specific program, S&C program, based around the Lift More principles. So our whole sort of team are educated in terms of the bone health principles, and we'll screen people beforehand using Echolight REMS to understand where they're at from a density point of view and a fragility point of view, and then safely load with good form. And it's amazing to see the confidence, the strength gains that people make, and not only seeing a reversal of their bone density scoring.
I think it was wonderful, and that when that paper first came out in 2017, that it was, as I say, it was a game changer, and it continues to be so.
I know, Nick, you've got a hard stop. One quick last question, what does bone health look like over the next 5, 10 years? Can you see a big shift or a change in emphasis or how we're delivering, our screening? Is there anything on the horizon, you think?
I think the question has to be split into which groups of people are you talking about. So we've got the people that
General population.
well, we split that up because we've got the people that come and see you and me, or Paul McGee in Amersham, and these are people who are very interested in themselves and in their health, and they want to do the best themselves because they might have, for instance, a mum or a grandma who's had osteoporosis, who's ended up with significant spinal deformity, lost a lot of height, a lot of pain, etc. And they don't want to be like that, so they're taking charge of themselves. So that group, I think, they will continue to do that, and they'll continue to look for better ways to both measure their bone health and also then to improve themselves. But the biggest part of the population, the biggest problem we've got, can't be addressed like that because actually that requires people to take some responsibility for themselves, and we know that actually human beings are pretty poor at doing that.
We're poor at behaviour change.
Yeah. So how do we nudge people? And I don't think, Simon, this is going to be, if we said 10 or 15 years, I don't think it's going to be the invention of a new device. I mean, sure, REMS is fantastic, and when it gets spread out, it's going to be, it will be a game changer in terms of diagnosis. But what we need to do, and I think, is look over the longer period of time. I'll go back to that 85-year time span. I say, look, why don't we go back to, it's not 85, it's 65. Why don't we go back to saying, okay, let's get into schools.
Yeah.
Let's get into schools and colleges and start to change the population from the baseline. That's the most effective intervention that we could do. Give people information, get them interested, get them to the stage where they're thinking, you know what? I don't want to be like my mum. I don't want to slow down. I want to stay vital. I want to stay healthy. And there is this big push now with longevity. And I think that longevity is a slightly misleading term because what it suggests is you're living longer. Actually, what I think we should be doing is living better.
Health span is perhaps a more appropriate term.
So I think if we can do that, if we can on the population level, we don't need new technology. We need new approaches to getting people interested.
Yeah.
And if we could do that, I think we'd make a big difference.
Nick, that has been amazingly insightful, super interesting. That time has flown by, but it's been, fantastic to have you on board and to be able to chat to you. And I thank you for your time. And I'd love to chat again, but thanks again, Nick.
Well, thank you for inviting me. It has been very enjoyable, and we've only scratched the surface, really, haven't we? Because there's a
lot more we could dive into.
You sent me some questions, and I think we've answered about 2 or 3 of them in full.
Exactly.
So, let's do it another time, Simon. That'd be great.
Thank you very much, Nick.
You're welcome.